This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 87 for July 20th, 2023. We're calling this one Vascular Anomalies and Malformations. I want to welcome all of you to the program. So we have another resident-led episode for you this week, which is really a great opportunity all around. You and I get an update on an important topic directly from experts in their field of study. In this case, as we consider vascular anomalies and malformations, our expert is Dr. Esteban Fernandez. He's a dermatologist at Nationwide Children's Hospital and an associate professor of pediatrics at The Ohio State University College of Medicine. And our pediatric residents get an opportunity to design and execute a CME activity by choosing a topic, selecting an expert, writing the learning objectives, conducting the interview, and constructing the post-test for those of you who will be claiming Category 1 CME credit. Our resident today is Dr. Elizabeth Nourse. She is a second-year pediatric resident here at Nationwide Children's, which, by the way, if you are a medical student looking to train in a pediatric residency, let me tell you, we have a really great one here, and I can vouch for it personally because this is where I trained. Several decades ago, but it was terrific then and it is terrific now. So please consider applying and perhaps you'll be able to put together a PediaCast CME episode in the future during your training. I'd love to meet you and collaborate with you while you're at Nationwide Children's. And a reminder for current pediatric residents at our hospital, if you're interested in getting involved with a future resident-led episode, shoot me an email and we'll get you moving in the right direction. All right, before we turn the reins over to Dr. Nourse and her interview with Dr. Fernandez, let's cover our usual quick reminders. Don't forget, you can find our podcast really wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. And also, please consider leaving a review wherever you get your podcasts so that others who come along looking for free continuing medical education credit will know what to expect. And speaking of that educational credit, it is really easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. We offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by many professional organizations, it's likely that we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We're also on social media. By the way, we love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, Instagram, and now Threads. Simply search for PediaCast. And there's that handy contact link as well over at PediaCastCME.org. Just use that if you would like to suggest a future topic for the program. Also want to remind you the information presented in every episode of our program is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Our discussion may contain only a portion of relevant information and should not be solely relied upon for the diagnosis or treatment of any medical condition. We do not cover every possible treatment option, and the treatment options we do cover do not include every possible use, precaution, side effect, or interaction. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Dr. Elizabeth Nourse and Dr. Esteban Fernandez settled into the studio. And then we will be back to explore vascular anomalies and malformations. It's coming up right after this.
Hi, Dr. Fernandez. Thanks for being here. Today we will be diving into the topic of pediatric vascular anomalies. But could you first define what a vascular anomaly is for listeners? Are there different types?
Hi. Well, first of all, thank you so much for having me. It is wonderful. This is a topic that I'm very passionate about, so I'm really excited to be here and be talking to you guys about vascular anomalies. So, vascular anomalies is really a term that we use to describe a group of disorders. It's really a group of disorders that is characterized by either abnormal vascular development or abnormal vascular proliferation. So, really, vascular anomaly is it's an umbrella term. So it's an umbrella term that we use to describe two main groups of vascular issues. So on the one hand, we have vascular tumors. For example, infantile hemangiomas are kind of the prototype of vascular tumors. And then on the other hand, as a separate group of vascular anomalies, we have vascular malformations. For example, capillary malformations or venous malformations, among other malformations. What's really interesting is that this classification really continues to evolve. It continues to change as we have a much better understanding of these anomalies. And in particular, in the last several years, there have been some great advances in our knowledge in the genetics of these conditions. Really, the discovery of different genetic variants of the different vascular anomalies, of the different pathways that are involved in these anomalies, have really changed the way that we think about these vascular anomalies. This new knowledge is really changing the way we approach these patients. It's really changing the way we treat these patients. So it is really a very exciting time in the vascular anomalies field. There's a lot of excitement, a lot of activity going on, and a lot of new knowledge every day.
Thank you. That's a great way to set the stage for the rest of the episode. Let's first talk about capillary malformations. What are the most common capillary malformations that a pediatrician will see on physical exam?
Yeah, so capillary malformations are one of the most common types of birthmarks that we're going to see. And so again, when it comes to vascular malformations in general, we're going to divide them kind of by the main type of blood vessel that makes up that malformation. So I mentioned we have the capillary malformations, which are made up of the dilated capillary blood vessels. So these tend to be the more superficial blood vessels in the dermis. Although we know that it's probably not just capillary blood vessels, we know that some of these vascular malformations, capillary malformations, are also made up of venules and post-capillary venules. So this is also part of the information that we continue to gather as we learn more about these. But these tend to be the more superficial blood vessels that we see on the skin. And for this reason, this type of malformations, the capillary malformations, typically have a pink or a red color on the skin. It's usually a pink patch or a red patch on the skin. Now, the most common capillary malformation is what we call the nevus simplex. And I like that term, although the more commonly used term is the angel's kiss when we see it on the forehead or on the face in little ones, or the stork bite when we see it on the back of the neck, the back of the scalp. Now, these are extremely common, even up to 80% in some studies, or some demographics have seen this type of finding, this birthmark, the nevus simplex, in newborns. So these are extremely common. We also have port wine birthmarks. The other term for port wine birthmarks is nevus flammeus, and this is going to be the second most common type of capillary malformation. Now, these tend to be a little bit darker. They tend to be a little bit more defined, and these also involve the superficial layers of the skin, but also go a little bit deeper into the capillary plexus, and that's the reason why they look a little bit darker in color. Now, you're probably noticing that I'm using the term port wine birthmark instead of the term port wine stain. You will still see the term stain used in many articles, in many descriptions in the literature, and that is still correct. Although we're trying to use the term birthmark instead of the term stain because it has a much more positive connotation. I think patients like it better when we call it a birthmark instead of a port wine stain. So that's something that it's a message that we're trying to get out there.
Awesome. Sometimes distinguishing capillary malformations can be challenging. For instance, if a 1-month-old presents to the office with parents concerned about a red birthmark on their daughter's face, how do pediatricians distinguish between a nevus simplex or stork bite and a port wine birthmark?
Yeah, that is a great question, and sometimes it can be tricky. The clinical features are going to be very, very helpful. So the nevus simplex, or the stork bite or angel's kiss, tends to be a little bit more ill-defined. It tends to be a little bit paler or lighter in color, so it tends to kind of blend in a little bit more with the surrounding skin. Kind of the borders are a little bit hazier. We cannot really delineate with a pen very clearly where that birthmark is. And again, because it tends to involve the more superficial capillaries, it tends to be a little bit paler in color. We know that capillary malformations change in color also based on temperature, or if the baby's crying, if it's warm outside. All of these factors play a role into the color. And sometimes the nevus simplex, sometimes it's actually very difficult to see, and the parents will tell us, well, the baby sometimes wakes up and I cannot even see it, and then you start to notice it. So that is also another clue that we use to make sure that it is a nevus simplex and not a capillary malformation or a different type of capillary malformation like a port wine birthmark, which on the other hand, they tend to be a little bit more red. They tend to be darker in color. The borders tend to be much more well demarcated, much more well defined. You can see exactly where it starts. You can see exactly where it ends. As a capillary malformation, port wine birthmarks also change with temperature, with activity, but very rarely completely fade away. And a nevus simplex, we often get that history from the parents when they tell us, sometimes I don't even see it, and then it pops up again. The other very, very important feature in the clinical exam that we use is the location. So when it comes to vascular anomalies, this is like real estate: location, location, location. It's really, really going to help us to differentiate, particularly between nevus simplex and port wine birthmarks. So nevus simplex tend to have very much a midline location. So we see it very often kind of on the forehead, more in the glabella area. The upper eyelids very, very often are involved as well. And we also see it on the nose, kind of tip of the nose or the philtrum, and even on the upper lip. So kind of midline. And the same when it goes on the back. We see it on the midline of the posterior scalp, or on the midline on the back of the neck. Sometimes they could even go further down the back, and often they go down midline. Now, very often in dermatology, when we see things that are midline, we get very concerned because midline is usually not a good thing. But this is one of those scenarios where it's actually the opposite. When we see this on a midline distribution and a midline location, then it's a lot more reassuring. On the other hand, port wine birthmarks, not only they're a little bit darker in color, usually more red, more well delineated. Port wine birthmarks tend to have more of a lateral distribution. So it's usually more on one side of the face versus the other. Sometimes they have actually a very sharp demarcation on the midline. So they get up to the midline and then they stop. Sometimes they go on both sides, but for the most part, they tend to have much more of a lateral preference. So these are the features that we use in the physical exam to distinguish a nevus simplex versus a port wine birthmark. And in most patients, that we can make that diagnosis based on physical exam, based on the findings and the history, but sometimes it can be tricky. Sometimes it's a little bit difficult to tell the difference. And sometimes we just need to follow these patients for a little bit longer to have a better sense of which one of the two it is.
As far as port wine birthmarks go, when should pediatricians be worried about Sturge-Weber syndrome, and when should pediatricians refer patients? Also, who should they be referred to?
Yeah, that's a great question. So one of the reasons why we care so much about these types of birthmarks is that not only the birthmark can cause some significant psychosocial problems in the future for the child, it can cause some medical problems in the future. Sometimes the birthmark is a red flag or a telltale sign that there's something else going on, or there's a risk of something else that could be happening. And Sturge-Weber is one of those situations. Sturge-Weber syndrome is really a neurocutaneous disorder that is characterized by abnormal vasculature of the skin, the eye, and the brain. And many patients have two of the three affected. You don't have to have the three of them affected to make a diagnosis of Sturge-Weber syndrome. Now, interestingly, our knowledge on Sturge-Weber syndrome has also significantly improved, and we know much more about this condition. In the past, we used to use the trigeminal nerve distribution, so the classic V1, V2, V3, to determine if a patient was at risk for Sturge-Weber syndrome. And it kind of makes sense at that time because we thought, well, this is something that involves the brain, right? And also something that involves the skin. What is that connection there? And we thought that trigeminal nerve was the connecting link there. And so we used to use the trigeminal nerve distribution as the risk categorization or the risk stratification for these patients. But we actually know that this is not true. It actually has nothing to do with the trigeminal nerve. We know now that the distribution of the birthmark on the face has to do with the embryological vascular development, which actually coincides with the development of the brain. And so there's been several studies looking at this, mapping the port wine birthmarks in patients with and without Sturge-Weber syndrome. And we now know that the best predictor for Sturge-Weber, or for patients who are at risk for Sturge-Weber syndrome, is a port wine birthmark that is located on the forehead, and typically involves a good portion of the forehead. Again, most of the time is on one side of the forehead, not on the entire forehead. Occasionally, we'll see it on both sides as well. Typically, this tend to be a little bit on the larger side, but there's also a lot of variability. Some patients have a relatively small port wine birthmark. This kind of forehead region, we also include the upper eyelid. Sometimes we see patients who have a port wine birthmark that involves the entire half of their face. Sometimes it's the entire face. The more areas of the face the patients have involved apart from the forehead, kind of the higher the risk of Sturge-Weber syndrome in this patient. The initial referral for these patients, the first part is to make sure we have the right diagnosis, to make sure that we have a patient who is truly at risk for Sturge-Weber syndrome. So in dermatology, of course, we're very used to seeing these patients and figuring out if these patients are at risk. Or also a vascular anomaly specialist. There are other centers where maybe a dermatologist might not be as readily available, but there are other specialists who might have experience and expertise in this type of vascular anomalies as well. So the first step is really to confirm the diagnosis and to confirm that this patient is truly at risk for Sturge-Weber syndrome. Often we send these patients to ophthalmology if they have particularly upper eyelid involvement. We want to make sure, or we want to rule out to see if these patients have that ocular component that characterizes Sturge-Weber. So patients who have a port wine birthmark on the upper eyelid or the forehead, if they're at risk for Sturge-Weber, we send them to ophthalmology. The main finding that we're looking for is glaucoma. That is one of the most common presentations in these patients. And then the other very important specialist for these patients is the neurologist, of course. So we send to our neurology colleagues patients who are at risk for Sturge-Weber syndrome. Often we'll send them so they can have a baseline evaluation, a very thorough neurologic evaluation, but also I think very importantly for them to better educate the parents on how to recognize seizures in an infant, which is not always the same way the seizures present in an older child.
Thanks for outlining initial red flags and the specialists who manage Sturge-Weber syndrome. What can pediatricians do to start the workup for these patients prior to their first subspecialty visit?
Yeah, so definitely pediatricians play a very, very critical role in recognizing these birthmarks, in recognizing this, which patients might actually require further evaluation. I think a thorough physical exam to really include a neurological exam would be very, very important for the pediatrician to perform to determine if the patient needs even a more prompt, for example, neurological evaluation. Even before coming to dermatology, there's some abnormal findings in the neurological exam. I think the other important part is the ophthalmology evaluation or the ophthalmology referral. The one thing that we cannot ask babies many things, but the one thing that we cannot really determine from symptoms or from signs is whether a baby can see well or not, if they're having any vision problems. And so we definitely rely and appreciate the expertise of our ophthalmology colleagues to determine if these babies are having any problems with their vision, if these babies are having any concerns for glaucoma, which again is kind of the most common complication or presentation in these patients.
Okay, great. At this point, I'd like to pivot to another very common vascular anomaly. Say I have a 3-week-old patient with a dime-sized raised red spot on her right thigh that looks like a hemangioma, and the parents want to know when it will go away. How do you distinguish a hemangioma on exam, and what's the typical course of infantile hemangiomas?
Yeah, that is a great question, and that is actually a very common clinical scenario. Infantile hemangiomas are the most common benign tumor in infants. Really, the most common benign tumor in childhood. These are very, very common. There's different studies looking at the epidemiology of infantile hemangiomas, and depending on the population that we're studying, it's even as common as 5 to even 10% of newborns or infants will develop or will have an infantile hemangioma. Now, remember what we were talking about before, the classification of vascular anomalies? And so now we're switching to the vascular tumor category. So the infantile hemangiomas belong to the vascular tumor. This is an abnormal proliferation of blood vessels. The natural course, the natural history is very important, and it can really give us a good sense of the diagnosis, confirm the diagnosis, and make sure that it's not other types of vascular tumors or other types of vascular anomalies. So as a vascular tumor, these are typically not present at birth. Or if we see something at birth, it's usually pretty faint. It's pretty subtle. But when we ask the parents to show us photos of their babies when they were born, which every single parent will have, you cannot really tell where it was. Or maybe you can see an area of pale skin where the hemangioma will eventually develop. And then the hemangiomas go through a very characteristic kind of growth pattern. They go through a period of proliferation, and usually this proliferation is a lot faster at the beginning. So we call this the early proliferation. And this usually happens in the first 2 to 3 months of life. It's actually pretty early. Typically, by about 3 months of age, most of the growth will have already happened in most hemangiomas. After this early proliferation, then the hemangiomas go into what we call the late proliferation. So up until 6 to 9 months of age, the hemangiomas can continue to grow, but usually at that point is a much, much slower growth. Really, the highest growth, the fastest growth is going to be really early on in the first 2 to 3 months of life. And then the other very important part to understand and to really explain to the parents is the involution part, or the going away part. So every parent is very excited to know that it's a benign vascular tumor and that it's going to go away. It's going to involute. Very often we'll have parents come to clinic and they come a little bit sad because the baby is 13 months old, 14 months old, and the hemangioma is still there. They were told that the hemangioma was going to be gone by 1 year of age. So it is very important to understand that involution starts around 1 year of age. In some patients, it can start a little bit earlier. In some, it starts a little bit later, but it's a slow process. It usually starts around 1 year of age and usually takes several years. What I usually tell parents is that this involution, this going away process, most of it happens in the first 4 to 5 years. About 80% of that process happens in the first 4 to 5 years. And often they go away enough, they involute enough that not much is left, but sometimes that involution is partial, meaning that some of these hemangiomas do leave some leftover changes, some sequela on the skin, some redness, some telangiectasias, or some kind of fibrofatty tissue that's kind of like soft, wrinkly skin where the hemangioma was. So the natural course is very helpful for us to make a diagnosis of an infantile hemangioma. One of the tricky parts with infantile hemangiomas is that hemangiomas come in different flavors, different shapes, different sizes, different patterns. And so the most common one is what we call a superficial hemangioma. And this is going to be the classic kind of strawberry red, bright red, either papule or a little plaque on the skin. Some are mixed, meaning that they have a superficial component, that bright red component, but there's also a deeper component, usually more of a dermal or subcutaneous component. So there's that bright bright red component on the surface, but a kind of a swelling or a fullness underneath. Those are the second most common types of hemangiomas, and then the least common type of hemangiomas are the deep hemangiomas. So some patients only have a deep component, meaning that you only see a swelling or fullness under the skin. Very often there's a bluish discoloration on the surface, so that helps us to determine that it is a vascular lesion or vascular tumor. With the purely deep ones, often we'll get some imaging, usually ultrasound, to confirm the diagnosis. But for the most part, the diagnosis of infantile hemangiomas is a clinical diagnosis based on the history, which is pretty characteristic, pretty typical, and then based on the clinical findings on exam.
What medical management can pediatricians provide for these patients?
Yeah, that's a great question, and I really think that early diagnosis and early evaluation, when it's indicated, is probably the most important factor in the management of these patients. I think it's important to kind of go back to the natural history of infantile hemangiomas, and again understand that most of the growth, or the fastest growth, is going to happen in the first 2 to 3 months. So it's a very time-sensitive issue. So we want to see these patients ideally early on, ideally in the first 1 to 2 months of life, when those hemangiomas are growing the fastest, and when an intervention, if an intervention is needed, if a treatment is needed, is going to lead to much better outcomes. Now, not every single hemangioma needs to be treated. Even though we have better treatment options, safer treatment options, that doesn't mean that we have to treat every single hemangioma. And this really is a shared decision making with the parents. There are some very strong indications for treatment. Others are a little bit more subjective. So we have a conversation with the parents as to what are the risks, what are the benefits of the different treatment options to make that decision. When we're looking at what are the indications or what are the reasons that we consider for active intervention, for active treatment, there's 3 main ones when we look at patients with infantile hemangiomas. One is if there is functional impairment or risk of functional impairment. A very, very common scenario is when we see babies with infantile hemangiomas around the eye. The eye, for some reason, is a very common spot for infantile hemangiomas. And if these hemangiomas grow, they push on the eye. They can cause some vision problems, and some, if they're not treated, they can be permanent. So that is definitely, that is one of those indications. Also, for infantile hemangiomas that are either on the lip or around the mouth, those can cause some problems with feeding, for example. So those are functional impairment risks that really indicate the treatment for these patients. The other indication is the occurrence of ulceration. Ulceration is a relatively common complication in infantile hemangioma. So the surface kind of breaks down. There's an open sore, there's an ulceration, tends to bleed a little bit, there's a risk for infection. It's very painful. And so this is another very clear indication for treatment. But probably the most common reason why we treat patients with an infantile hemangioma is because of the risk of deformity. The risk that hemangioma might go away, but might not go away completely. The risk that these hemangiomas might just partially involute and might leave changes on the skin, some permanent changes that then could cause some psychosocial issues for the patient as they get older. So some of these patients might require surgery in the future or laser in the future to kind of revert those changes or make those changes better. So for these patients, if we can start treatment early on to prevent that from happening, then that would be ideal. But again, this is really a shared decision making with the parents. As far as treatments, beta blockers have absolutely become first-line treatment options for these patients. Propranolol is FDA approved to treat patients with infantile hemangiomas, patients who are 5 weeks of age and older. Propranolol, systemic propranolol, is really ideally managed by a hemangioma specialist. Depending on where you are, you may have somebody close. Other locations might not have somebody close by. The other medication that we use very often is topical timolol. This is off-label use. It's a topical beta blocker, which has ophthalmic indications. It doesn't have cutaneous indication, but we use it on the skin. And we've really we come to learn that timolol works well for a very select group of patients. So usually timolol, we want to reserve it for patients who have small hemangiomas, very superficial hemangiomas, and uncomplicated hemangiomas. So if I see a patient with a small superficial hemangioma around the eye, but if there's any potential risk for vision impairment, then timolol is probably not the best option. If there's any risk for functional impairment, we probably want to go with a systemic option. So everyone has a little bit of a different level of comfort when it comes to these medications. It can also be very regional, whether you have a hemangioma specialist close by or not. There are some really good documents out there. The American Academy of Pediatrics, they published the clinical practice guidelines on infantile hemangiomas not too long ago, which is a really good document to review if you need to for your patient.
I'm going to just jump in really quickly. I was wondering, with using beta blockers for these babies, do they have any side effects or complications or contraindications to the use of those?
Yeah, absolutely. That's a great question, and that is definitely a conversation that we have with the parents every time we consider this type of medication. Propranolol, again, is the beta blocker that is FDA approved to treat infantile hemangiomas. There are other beta blockers that we use off-label in certain situations. So the more concerning side effects of propranolol would be particularly hypoglycemia, especially in little ones, and then the risk of bradycardia, the risk of hypotension. Overall, the risk of this more concerning side effect is pretty low. Really, the more concerning one is the risk of hypoglycemia. So it is very important when we counsel these parents, when we are counseling them on this medication, is to always educate them on the importance of giving this medication with meals. That way, we'll decrease the risk of hypoglycemia. Also, to try to space it out so that as babies get older in infancy and they start to sleep more through the night, to try to space it out and not give it too close to their dinner or before bedtime meal, so that they don't spend a lot of time fasting overnight until they wake up in the morning. So the hypoglycemia is a very important potential risk factor. Overall, the risk is pretty low when we educate the parents and when it is given appropriately. The other time when we ask the parents to hold off on giving propranolol or other systemic beta blockers is when babies are sick. When babies are sick, then the risk of hypoglycemia is going to be higher, and they might not eat as well, and so if possible, we hold off on propranolol in those scenarios as well. More commonly, as more common side effects, some babies tend to have a little bit of more reflux, which is already common in babies. So is it really the medication, or it happens in babies? Hard to tell. Sometimes it's more the formulation than the medication itself. So there are some formulations that tend to cause a little bit more of this reflux issue. The other side effect that nobody likes is that sometimes these babies don't sleep as well. And we don't know if it's the medication or if it's because babies don't sleep well often. But some parents do notice often that when the medication was started, they stop sleeping well. They wake up more often. They wake up crying, almost like having nightmares. And so that is another potential risk. I have to say, I don't see those side effects very often. If anything, probably the more common one is the reflux, the kind of the stomach upset. But for the most part, babies tolerate propranolol. They tolerate beta blockers very, very well. The other important time when we want to hold off on the medication or take a break from the medication is in the case of respiratory infections. So for two reasons. One is a higher risk of hypoglycemia. But then the other risk, as a beta blocker, we don't want to make bronchoconstriction worse. And so, especially for the little ones, if they start to get some bronchiolitis, that is definitely a time to stop the medication. As far as contraindications, there's some kind of absolute contraindications, some relative contraindications. So patients who have cardiac conditions, these are definitely patients that we want to have a conversation with cardiology to see if they are good candidates for it. If they have heart block, if they have bradycardia, then a beta blocker is probably not going to be the best option. If they have congenital heart anomalies, we want to have a discussion with the cardiologist. It doesn't mean that we cannot use the medication, but those are some potential contraindications. And the other important one that we see, particularly with preemies, is if preemies have respiratory issues, if they have bronchopulmonary dysplasia, they might still be on supplemental oxygen. We don't want to make, of course, those respiratory symptoms worse. So these are babies who maybe we will consider a different type of beta blocker. So we might consider atenolol, also off-label, but atenolol is cardioselective. So it tends to not have the respiratory issues. So we definitely consider a multitude of factors when we are discussing this treatment option. For the most part, babies do very, very well. They tolerate this medication very, very well, and most patients respond very nicely as well.
Thank you so much for teaching us about hemangiomas and beta blockers. So most infantile hemangiomas are benign, but what are red flags for hemangiomas?
Yeah, that's also very, very important to know. So I mentioned kind of the indications for treatment. What are the situations? What are the scenarios that make us think more actively about starting a medication for these patients? Now, sometimes the infantile hemangioma might actually indicate that there might be something else going on, kind of similar to the port wine birthmarks in some patients. Sometimes the hemangioma is just the tip of the iceberg, and we need to do other evaluations to make sure that we're not missing some potentially very important complications. One of those scenarios is when we see babies with multiple hemangiomas on the skin. And so when we have a baby who has 5 or more hemangiomas on the skin, and we call this multifocal infantile hemangiomas, these are babies who are at risk to have visceral involvement of these hemangiomas. And the most common place where these hemangiomas are, if there is visceral involvement, is the liver. And so these are babies who are at risk for hepatic hemangiomas. Most patients don't if they have 5 or more, but we always want to make sure that we have ruled that out. So for babies who come in with 5 or more infantile hemangiomas, then these are babies that we often get an abdominal ultrasound to rule out hepatic involvement. Of course, if a patient comes in with 3, but they have hepatomegaly, they have abdominal distension, clearly those are patients that we want to work up as well based on your physical exam. The other scenario that is very important to understand, and it's kind of very similar to the Sturge-Weber syndrome situation, is the risk for PHACE syndrome. So PHACE syndrome is something that we consider in patients, particularly if they have a segmental hemangioma that involves the face, the neck, the face and the scalp, and often the neck as well. Segmental hemangioma, segmental means that it is a hemangioma that involves more of an anatomic region. It's not the typical hemangioma that develops from one focal point. It's not a papule or a nodule. It's more of a plaque, and it tends to have more of this kind of geographic map-like border. So patients who have a segmental hemangioma on the face, on the scalp, and often on the neck as well. Typically large, and by large, we use a cutoff point of 5 centimeters. That's also a little bit variable, but 5 centimeters is a good kind of cutoff point for these patients. Then we have to do some further evaluations. When these segmental hemangiomas are on what we call the beard distribution, so the mandibular area, the lower lip, chin, anterior neck, these are patients who are potentially at risk for airway involvement. These patients can have subglottic hemangiomas, and you can imagine if the hemangiomas grow in the skin, they can also grow in the airway, but there's not a lot of leeway in the airway. They start to grow in the airway, they can cause obstruction very, very, very quickly. So that is one of those emergency situations. So if we have a patient with a hemangioma, particularly segmental hemangioma in the beard distribution, we really want to ask about respiratory symptoms. We want to ask about stridor. How are they sleeping at night? We want to make sure that is not an issue. Another location that we look for is hemangiomas that are in the lumbosacral area. Not every hemangioma in the lumbosacral area is a risky hemangioma, and the risk that we consider here is the risk of spinal dysraphism. So again, the hemangioma might just indicate kind of the tip of the iceberg, that there's something more concerning underneath. The main risk for these patients is for patients who have a bit of a larger hemangioma, so more than 2.5 centimeters. That's usually the cutoff point that we use based on some studies as the kind of at-risk size in these patients. And similar to patients with PHACE syndrome, where they have the segmental hemangioma of the face or the kind of upper body. There's another syndrome called lumbar syndrome, and that's an acronym, and that is much, much less common, but that's what we call the face syndrome of the lower body. So these are patients who have a large, typically segmental hemangiomas in the perineum, lumbosacral area, lower extremities, and they are at risk of a multitude of other kind of internal anomalies, structural anomalies. So we call that lumbar syndrome.
Thank you so much for going through those. Could you tell us a little bit more about face syndrome? And are there any labs or imaging that might be useful to confirm these diagnoses?
Yeah, absolutely. So PHACE syndrome is an acronym. It's PHACE. And this is an acronym that stands for P is posterior fossa anomalies, H is for hemangioma, A is for arterial anomalies, which can be cervical arterial anomalies or brain arterial anomalies. The C is cardiac anomalies, and most commonly this is coarctation of the aorta. And the E is for eye or ocular anomalies. Sometimes we add an S at the end to describe some midline problems, so like sternal problem, sternal cleft, or supraumbilical raphe type of findings. But we usually stop at the E for the acronym of PHACE. Again, patients who are at risk for PHACE syndrome are patients who have a segmental facial hemangioma, typically more than 5 centimeters in diameter. Again, this can be a little bit variable. It can be on the face, it can be on the scalp, sometimes on the neck as well. There are some rare situations of face without a hemangioma or face syndrome without a hemangioma on the face, but those are pretty rare. So for the most part, the patients that we really want to look for are those who have a larger hemangioma on the face. And what's been shown is that patients who have a large facial segmental hemangioma, about 30% are at risk for PHACE syndrome. So it's not that negligible, that risk that we look for. This is a scenario or a situation that requires quite a bit of an evaluation. So we want, of course, to make sure that we want to rule out those potential anomalies, structural anomalies that these patients may have. So these are patients that require quite a bit of imaging. We need to image the brain. We need to image the neck. It is very important to get an echocardiogram to make sure, particularly, that these patients don't have coarctation of the aorta, which is one of the more common kind of cardiac manifestation. And then ophthalmology evaluation. So these are patients that if we have a patient with PHACE syndrome, depending on their findings, depending on what they have, these are patients who really require multidisciplinary management. We might discuss these patients more with cardiology or with neurology, depending on the manifestations, on the findings that they have. From the pediatrician standpoint, I think recognizing the potential risk in these patients, it's going to be very important, and try to get them to a hemangioma specialist or a specialist evaluation as soon as possible. I think these are scenarios that if you're thinking about this possibility, I think more than just faxing a referral, I think picking up the phone and talking to a friend that might be more used to seeing these patients, I think that would be very helpful. An echocardiogram is always very valuable to have in this patient. So that might be something that could be done before they see the specialist. Of course, it depends a lot on whether the patient is symptomatic or not. Right? In otherwise healthy babies and babies who are growing well, developing well, don't have any neurologic problems or any other manifestations, we have a little bit more time. If patients are symptomatic, then we have to do things a little bit more urgently. And the other evaluation that might be helpful to get beforehand is the ophthalmology evaluation. That's another one that can be kind of cooking or can be done even before the hemangioma specialist evaluates this patient.
We're a little bit at a disadvantage because we're an audio podcast and we can't show pictures, which is very helpful when we talk about dermatology stuff. When you say segmental hemangioma in the beard area, what do we mean by that? Like, what's a good descriptor of a segmental hemangioma?
Mm-hmm. So a segmental hemangioma, again, it's going to be a hemangioma that involves an anatomic region. So most hemangiomas, if we look at images of hemangiomas, most hemangiomas kind of develop from a focal point. They look like a papule or a nodule. So they look like a little ball that is developing or evolving from a focal point. A segmental hemangioma, it's not a focal point. It's a plaque. It's an entire area of the skin where it is coming from. And so it is not not one area, but it's a combination of anatomic regions. So it usually looks more like a plaque. It's a little more elevated, and that is what we call a segmental. That is a segmental morphology in these patients. And depending on where it's at, that's where we consider the risk. So as you mentioned, in the beard distribution, that's where we start to think about not only PHACE syndrome, probably, but also the possibility of airway involvement.
Thank you so much for going through several serious vascular malformations. As we get closer to wrapping up, I was hoping to briefly touch on a couple other common ones. Say I have a 4-month-old with a bleeding mole that parents are very worried about, and I suspect a pyogenic granuloma. What distinguishes a pyogenic granuloma on physical exam, and what's the best thing a pediatrician can do in the office to treat this bleeding mole?
Mm-hmm. Yeah, these bleeding moles can be pretty pesky. Pyogenic granulomas are very common. The other term for pyogenic granulomas is lobular capillary hemangiomas, which is very confusing because we are mixing a lot of different terms that probably don't make a lot of sense. So that is the other point that I wanted to make, is that we often use the term hemangioma to describe anything that is red in a baby. But as we've been talking, you can see that what we call these different vascular anomalies is very important, because the management is going to be very, very different in each scenario. So pyogenic granulomas also belong to the vascular tumor category. This is a benign vascular tumor. We see this at any age. If anything, we actually don't see this as frequently in infants. We usually see them more in toddlers or school-age kids, adolescents, really at any age. So if anything, in infancy, we don't see them as frequently. So even just with the history, even though they can sometimes look like a hemangioma, they can look like a very small hemangioma. They look like a cherry red papule on the skin, but you get the history and it is not a hemangioma. Oh, they just noticed it after 12 months of age. Well, that cannot be an infantile hemangioma. This is more likely to be a pyogenic granuloma. So they tend to be small. They tend to be kind of pedunculated, very friable papules. These are little papules that if you look at them, they start to bleed. These can be very, very small. They're small but mighty. This can bleed quite significantly. It's very, very interesting when we see these patients, and I asked the parents to show me pictures of what it looked like when they woke up, and not infrequently they will show us a photo of their baby in their crib smiling, but it looks like a murder scene. There's blood all over the place. So when these bleed, they can bleed quite a bit. Not infrequently, they go to urgent care because the parents are unable to stop the bleeding, because of course you're trying to, especially if you're dealing with a baby or a toddler, you're trying to put pressure in a little one. Well, good luck with keeping him steady and not moving, right? And so sometimes parents can have a hard time stopping the bleeding. Things that can be done in the office, and many pediatricians might have this available, things like silver nitrate, cauterization. Those can be very helpful. Might not completely make the pyogenic granuloma go away, but it can be very helpful for the bleeding part. So kind of treat it almost like an umbilical granuloma, which I think is something that pediatricians will tend to see more. The more kind of definitive treatment would be a shave excision with cauterization at the base. That's something that we'll often do in clinic, but considering silver nitrate, cauterization might be good ideas for the office. The other type of treatments that we use for these patients, off-label, of course, is timolol. Since we discovered that timolol works for some vascular things, we've been using for other vascular tumors like pyogenic granulomas. And it doesn't always work, but in some patients it can work. And particularly, I found that it works better to kind of help with the bleeding, let them let it settle down so we can see them in clinic. We'll occasionally also use very high potency topical steroids. So we're talking, class 1, class 2, so pretty high potency topical steroids and sometimes that can be enough to make the pyogenic granulomas go away. Of course, we have to be a little bit careful here because most of the time we see these pyogenic granulomas on the face, of course. And so we're talking about high-potency topical steroids on the face. So we want to be a little bit careful with that, but that can be another possibility. I found Timol to be helpful, mostly for to help with the bleeding part, and often it makes them smaller than any type of excision or any type of removal, surgical removal, ends up with a smaller scar. But yeah, these are very, very common, and they can bleed quite a bit. I'm always impressed on how much bleeding these little pesky pyogenic granulomas can have.
Do the pyogenic granulomas, do they tend to just occur spontaneously, especially in older kids? And I think I've read somewhere about there being an association with injuries and like a healing injury than getting a pyogenic granuloma that develops there. Is there truth to that?
Yeah, that's a great point. So not unusually, we'll have a history of, oh yes, their son or their daughter had a little scratch there, and then as the scratch was healing, then the pyogenic granuloma developed. So yes, sometimes we do have a history of a previous trauma. It could be a scratch, even like a bug bite, or any type of trauma to the skin, and it's like an overreaction of the skin as the skin is. Very often also, we don't really get a clear history or any good history of trauma. There was absolutely no trauma, and these just develop. So very often these just develop spontaneously. Occasionally we do get the history of previous trauma. So I do think there's something to it. We also see this type of growths more commonly developing on top of other vascular anomalies or vascular malformations. So particularly with port wine birthmarks, as the patients get older, sometimes these birthmarks become darker, they become thicker. And this is one of the potential kind of complications. They start to develop these pyogenic granulomas on the surface. But for the most part, we see this in patients who do not have any other vascular anomalies at all.
Okay, great. I've also had patients come to the office concerned about telangiectasias on the face or on the arms. Often concerns are cosmetic, but when should pediatricians be worried about more than cosmetics?
Yeah, so this is also a very common scenario that we see in our clinics. So typically these patients will come with what's called a spider angioma. So it's a little dilated capillary blood vessel with kind of like spidery legs or spidery veins surrounding a central spot or a central papule. We see this very, very often on the face. I also see them very often on the hands as well. We don't really know why this happened. Sometimes we think that maybe sun exposure has something to do with it, just because we see it mostly on very sun exposed areas. So especially on the cheeks, on the malar cheeks, the nose, those are very common spots where we see it. Typically, patients will come with 1 or 2, maybe 3, but usually it's very, very limited number. And these are, again, extremely common. We don't have to get too concerned about that. We should start to think of other potential conditions. This would be rare scenarios, but we have to consider it if we have a patient who has multiple. They have a bunch of these on the face. They are a little bit larger, more matted looking. Or if the patient has these type of findings on the lips or the tongue, kind of more mucous membranes, they should not be developing the spider angiomas on those areas. We want to ask about any history of recurrent nosebleeds, recurrent epistaxis. Then that can lead us in a different pathway. Could this be associated with HHT or hereditary hemorrhagic telangiectasia or other potential syndromes associated with these findings? But again, in the vast majority of patients that we see in clinic, these are isolated. We don't really understand why these happen. We don't know why these happen, but we see them very, very commonly.
Awesome, thank you. At this point, we've gone through some of the most common vascular anomalies. However, we also have to watch out for other types of vascular malformations that may be less common. What are other vascular malformations, and how do these typically present?
Yeah, great question. So going back a little bit on the classification, so we've talked about the capillary malformations. So we've talked about nevus simplex. We've talked about port wine birthmarks, which belong to that capillary malformation group. But there are other types of malformations that we classify them based on the blood vessel that makes up that malformation. So apart from capillary malformations, the main categories of other malformations are venous malformations, lymphatic malformations, and arteriovenous malformations. Not infrequently, we'll see a mix of some of these. So we might see a veno-lymphatic malformation. So some patients do present with a mixture of this, of the different components. They're going to have very different presentations. So for example, venous malformations will tend to have a very kind of soft, squishy feel to them and kind of have this kind of bluish color on the surface. Sometimes they look more like varicosities on the surface. The degree of involvement or how deep they go, it's super variable. It can be very superficial. It can go much deeper into the muscle or the bone or the joint. So that is very, very variable. Venous malformations can sometimes get little blood clots within that malformation. We call those phlebolyths, and those can be painful. Patients often experience swelling, pain when this happens. Lymphatic malformations have also a very different type of clinical presentation, and there are different types of lymphatic malformation. There's macrocystic, microcystic, mixed, cutaneous lymphatic malformation. So some might just look like a swelling under the skin with no skin color changes. Others look like little vesicles kind of grouped together on the skin, and they can have some drainage, some seeping, some weeping. That's another presentation of lymphatic malformations. Arteriovenous malformations are less frequent, fortunately, because they tend to misbehave more. These often present with an area that might look more red or more pale, but it's often warmer to the touch, and you can feel some pulsations because there's much more rapid flow, much more fast flow going through those arteriovenous malformations, often with swelling of wherever the body site it is. And of course, the mixed malformations, you get a combination of the different components depending on what makes up the most.
It sounds like some of these vascular malformations and anomalies can be quite complex. How are these anomalies typically managed? Are other specialists involved in the care of these patients?
Yeah, you're absolutely right. So some of these patients can be quite complex. Many of these patients do require multidisciplinary management. And here at Nationwide Children's, we're very fortunate to have an absolutely wonderful group of specialists. So we have a vascular anomalies center, and there's a number of specialties that we come together to see these patients, to discuss these patients, to manage these patients. So we have interventional radiology, plastic surgery, we have hematology, oncology, genetics, of course, have become very, very important in our group. We have pathology, we have psychology, we have a very large number of very dedicated people and specialists that take care of these patients. So we're very fortunate to have this group of people here and to be able to provide very good multidisciplinary care for these patients. And the reason why we need all of these people is because the treatment can be very variable. Also, the evaluation is going to be very variable for each patient. We often need to do quite a bit of imaging to determine where is the malformation, how deep does it go, what are other organs or what are other structures that malformation might be affecting. And then when it comes to therapy, there's different types of treatment options for these patients, again, depending on the specific case. Sclerotherapy, for example, is something that is done by interventional radiology, which can be very helpful for many of these patients. Sometimes these are patients who are surgical candidates. So our plastic surgeons are experts in managing these patients as well. Something that has become very, very exciting and interesting is, I mentioned before, our knowledge on the genetics has really evolved and has significantly increased. So as we learn more about the genetics of this, particularly the more complex vascular anomalies, we have started to use more medical management for these patients. And what's interesting is that many of these vascular anomalies have variants or mutations in genes that are also shared with tumors, with cancer. And so we have started using some medications that are more typically used by our hematology oncology colleagues, and that's one of the reasons why they are a very important part of our group. Because fortunately, we're able to offer offer more medical management for these patients as we continue to learn more about the underpinnings, as we continue to learn more about the genetics, the pathophysiology, all the different mechanisms that are involved in the development of all of these vascular anomalies. So really shout out to our multidisciplinary group. It's a wonderful group of colleagues. We are very passionate about this. We meet once a month to see patients in person in a multidisciplinary clinic fashion, and twice a month to discuss these patients virtually. So we have quite a good number of patients that we take care of in this multidisciplinary group.
Dr. Fernandez, thanks so much for taking time to talk with us today. Vascular malformations and anomalies are varied and can be challenging to diagnose and manage in the primary care clinic. But pediatricians, be empowered to care for kids with these skin findings. The primary care clinic is the first line of diagnosis and treatment, even before making it to the dermatology office. Thanks again to our listeners for tuning in to learn about vascular malformations and anomalies. And Dr. Fernandez, thanks again.
Thank you. It was absolutely my pleasure to join you and talk about this very interesting topic to me.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks to our guest and interviewer today, Dr. Elizabeth Nourse. She's a pediatric resident at Nationwide Children's Hospital who put this episode together. Really great job, Elizabeth. And of course, Dr. Esteban Fernandez Faith, a pediatric dermatologist at Nationwide Children's. Always great to have him on the program. Once again, don't forget, if you're a current resident at Nationwide Children's Hospital and you would like to collaborate on a future resident-led episode, please shoot me an email and we'll get you started. Lots of links today in the show notes over at PediaCastCME.org. Of course, we have a link to dermatology and primary care, since those are two service lines that we mentioned. Also, a link to the pediatric residency at Nationwide Children's Hospital, if you'd like to learn more about that, particularly for medical students out there who may be interested in going into pediatrics as a career. We do have some links to up-to-date articles, infantile hemangiomas, the epidemiology, pathogenesis, clinical features, and complications of infantile hemangiomas. Also one on Sturge-Weber syndrome. So those will be helpful if you'd like to learn more. And then a couple journal articles that we have, port wine birthmarks, an update on diagnosis, risk assessment for Sturge-Weber syndrome and its management. Also clinical practice guidelines for the management of infantile hemangiomas and the infantile hemangioma referral score, a validated tool for physicians. We have a textbook, Pediatric Dermatology, a quick reference guide, the 4th edition, that was used as we researched this particular episode. And then we also have a link to a PDF that is the infantile hemangioma referral score. So lots of references and resources available for you there in the show notes. Don't forget, you can find us wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You will find our entire archive of past programs there, along with our show notes, CME information, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Also Threads. Simply search for PediaCast. So you've listened to the podcast. Now be sure to claim your free Category 1 continuing medical education credit. It's an easy thing to do. Simply head over to the show notes for this episode. Again, they're at PediaCastCME.org. Look for the show notes for this episode. It's 87. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME. Take and pass the post-test, and the Category 1 credit is yours. It's free, but you will need to sign up for a Cloud CME account if you do not already have one. Super easy, right? And again, we do offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also, don't forget about our evidence-based podcast for moms and dads, a plain PediaCast without the CME. Lots of pediatricians and other providers also tune in as we interview pediatric and parenting experts, cover pediatric news, and answer listener questions. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.